Hello and welcome. Thank you for joining us today for our Autism in Primary Care Education Series. This series is brought to you by the Ridge Meadows Division of Family Practice Child and Youth Autism Project, in collaboration with pediatrician Dr. Anna Maria Richardson, through funding provided by the Shared Care Committee. My name is Dr. Liz Zubek. I'm a family physician and practice in Maple Ridge in beautiful British Columbia. I'm also one of the Ridge Meadows Autism Project physician leads. We received feedback from our community family physicians, nurse practitioners, and pediatricians that they were unclear about the autism assessment and diagnostic pathway. They expressed a lack of clarity about what community and provincial resources were available and were unsure about best practices to support their patients, parents, and caregivers. With the prevalence of autism on the increase, and approximately 1 in 50 children across Canada being diagnosed with autism in 2023, it is more important than ever for family physicians to know how to support their patients and their parents' caregivers. So, without further ado, I'd like to introduce you to Dr. Richardson, a dedicated pediatrician based in Vancouver, BC. Dr. Richardson's journey into pediatrics was sparked by her interest in behavioral complexity as a high school teacher. Today, she stands as a fervent advocate for health equity, which has resulted in a research program that aims to better understand the needs of specific patient populations and identify leverage points for system change. She is a firm believer in that we can always do things better. As a qualified specialist doing autism assessments, she has a huge appreciation for the challenges in identifying, assessing, and managing kids with complex behavioral needs. Please welcome Dr. Anna Maria Richardson.
Hi, I'm Anna Maria Richardson. I'm a community-based pediatrician, and I'm really happy to be invited to present here today. I work in Vancouver, which is part of the unceded, stolen ancestral territories of the Musqueam, Tsleil-Waututh, and Squamish First Nations. On this land here, I'm a community pediatrician, which means I have my own clinic. And I see patients that are referred to me. I went into pediatrics, graduated in 2017, and from that time I have slowly been gaining a lot more understanding and a focus on neurodiversity and specifically autism. And through interest and through collaborations, I've been able to partner with Ridge Meadows Divisions of Family Practice to create a toolkit. And from a toolkit, we now have the presentation. So it's going to be a 3-part series. Part 1, just a bit of background and a bit of my personal interests around language and intersectionality and like where autism came from, the label. And how we actually diagnose it. Part 2 is going to be more directed towards primary care and about using screening and surveillance and what are the co-occurring conditions that you tend to make me wonder about an underlying autism diagnosis. And then part 3 is what to do after the diagnosis. So for part 1, I think it's important to know that these are my opinions. These are the things I've learned and I think are important. I think it probably reflects on my background and my focus on health equity. And I'm pretty sure that part of where that comes from is my personal background as a as somebody born in South America, even though I look and sound very Canadian, very white Canadian, I did grow up in South America, and other things that I think are important to me. I went through medical school and residency as a single parent, which again really make me think about how things are a lot harder for some people. And so the first thing I want to talk about is racism, the use of language, and the double empathy problem. I think people, and by people I mean clinicians, practitioners, worry about whether or not they're using the right language. I think language is incredibly important because it really helps you formulate how you're seeing people. And so initially when autism was being identified, people were referred to as unautistic, like, oh, that's unautistic. And in the 1970s, I think with all the critical disabilities advocacy that happened, people wanted to shift to person-first language. And that's where language became a child with autism or a person with autism. And the idea there was just to move away from just being a diagnosis, right? However, like as time went on, people, and especially autistic self-advocates, started identifying that you can't really separate autism and identity, and so they moved to an identity-first language. And so now more commonly we talk about an autistic child or an autistic person, or somebody might say I'm an autistic self-advocate. And that's similar to the positive, the way you talk about a smart child. You wouldn't say a child with smart, because that's part of who they are. Other language that I think is important to consider, we're moving away from comorbid or comorbidities. We're moving towards co-occurring conditions. We're moving away from disability or disorder to differences. We're moving away from dysmorphic features to distinctive features. So all language that's trying to just be a bit kinder, I think, to people. Perhaps if you're corrected by a patient or by a family, listen and wonder and maybe think about if their options or choice of words might be a bit more kind. Autism in general is diagnosed much earlier in white communities. So racialized communities receive an autism diagnosis much later. There's about a 3-year delay in one study, the other studies have identified that the delay actually increases with socioeconomic status, with rurality, and with being part of a minority population. In Canada in particular, there is wonderful work being done on fetal alcohol spectrum disorder. And there's a paper, and I'll read a quote, that there is an erasure of Indigenous autistics and homogenization of Indigenous neurodiversity under the heading of FASD. And so as a clinician, I think it's incredibly important to check our own biases and wonder when we're sending a referral for a child, when somebody comes in and they are affected inequitably by intersectionality, that we really be mindful of what we're seeing and who we refer to. The other topic that I really love is the double empathy problem. And it was developed by Milton in 2012. He is a scholar. He tried to formulate that the problem isn't autistic people. The problem is the difference between autistic and non-autistic people. And that as a neurotypical physician, I need to realize that. And so I'll read again a quote from his paper. In the case of autism, a communication gap between people with and without the condition may occur, not only because autistic people have trouble understanding non-autistic people, but also because non-autistic people have trouble understanding them. And so I think that every time one of my patients has difficulty accessing care, I don't think they're the issue. I think it's that mismatch between the system that tends to cater towards non-autistic people not meeting their needs. So that's, I think, been the driving force for me doing this work. It's about trying to reimagine a system where we can actually do a lot better. So I'll spend a little bit of time going through just autism, where the word came from, what the diagnosis is, the trajectory, the changes that have happened over the past 50 years or 70 years. So the word autism initially was an adjective, and it was coined by Bleuler in 1912. And it was a word to mean morbid self-absorption. It's embarrassing now to think about that. 1938, Asperger developed or coined the term autistic psychopaths. Again, there's very negative connotation with autism, which again is embarrassing to think about. Kanner in 1948 felt that refrigerator mothers, so cold parenting, caused autism. And so, again, embarrassing to think about. And the controversy, I think, around this is like still part of the issue today. Autism is still viewed negatively, and really, in my opinion, it's a description of behavior. The DSM-5, the Diagnostic Statistics Manual, is where we get our criteria for diagnosis of autism. So under the heading of neurodevelopmental disorders, or NDD, is where you're going to find autism. And NDD are a group of conditions with the onset in the developmental period. The disorders typically manifest early in development, often before the child enters grade school, and are characterized by developmental deficits that produce impairments of personal, social, academic, or occupational functioning. The subheadings under NDD are varied, includes intellectual developmental disorder, which I prefer to call intellectual impairment, and global developmental delay when there's deficits under the age of 6. Communication disorders, ADHD, ASD, learning disorders, tic disorders, and motor disorders, so stereotypies and developmental coordination disorder. So this is where you might find people using the broad terminology neurodiverse or neurodevelopmental disorders. That is where it encompasses this whole constellation of subcategories. But there's also generally neurodiversity is felt to be one-to-one with autism, but really it incorporates all of these conditions. So autism itself, again with the DSM, DSM-1 came out in 1952, the first version, and autism was a symptom in that point, again an adjective under schizophrenia. The whole idea about people turning inward, so autoism. DSM-2 in the 1960s is where childhood schizophrenia was identified, and that is what has transitioned into autism. The DSM-3 in the 1980s, childhood schizophrenia was removed and it became pervasive developmental disorder, or PDD. And in the 1980s, the incidence of autism was about 1 in 10,000. In 1990s, the DSM-4, the PDD became 5 different subcategories, or 6. And that's where things were divided: autistic disorder, Asperger's, childhood disintegrative disorder, and PDD. The incidence, again, 1980s, 1 in 10,000. Now in the 90s, 1 in 1,000. Finally, the DSM-5, 2013. All of those categories were brought down into Autism Spectrum Disorder. And now we're at an incidence of 1 in 100. But this is where you're going to find that some people are still using the language of Asperger's or PDD. It's from the old DSM. So the diagnostic criteria for autism are found in the DSM-5, and it is deficit language, which again I don't fully agree with, but in order to meet criteria for autism, you need to have deficits in 2 categories. One of them is social communication, and one of them is restrictive repetitive behaviors, and I call that RRB. You'll hear me using that term. Deficits in social communication, there's 3 categories under that, and you need to have difficulties in all 3. The first one is social emotional reciprocity, so back and forth, conversation, sharing, offering, showing, initiation of engagement. The second part is nonverbal communication, gestures, eye contact, facial expressions. The third part is developing and maintaining relationships, imaginative play, understanding and maintaining those friendships. So you have to have 3 of 3, and then the second part, you need to have 2 of 4 of the RRBs. So the first one is stereotypies, and typically the hand flapping or finger movements or jumping really hard, rocking, spinning, just repetitive movements in general. The second heading would be insistence on sameness, and that difficult with transition, difficult giving up, their toys, their need to have things kind of done one way. The third heading is highly restrictive interest. So, a child might be interested in dinosaurs, but a child with autism might be really interested in dinosaurs and everything is dinosaur. And then the fourth part is sensitivities. And so you can be hypo or hypersensitive to things. So not very sensitive, you don't care, or very, very sensitive. People licking things, sniffing things, blenders, the toilet flushing, covering their ears, not wanting to wear certain clothes, very picky eating. Though that would be examples of sensitivities. And so 3 of 3 for social communication and 2 of 4 for restrictive and repetitive behaviors. Since the movement from the DSM-4 to the DSM-5, when autism became one category, the Autism Spectrum Disorder, people wonder about how it can be so big, and it's true. The incidence right now, as I mentioned, from the 1980s to 1990 to 2000, we're now in the US at 1 in 36, and British Columbia 1 in 29. It might even be 1 in 26 here, with a male incidence in the States of 4.3%. Recent study in the UK in 2018 looked back over 20 years, and there was an almost 800% increase in the diagnosis of autism. People have looked into why, and I don't think there is one answer. I don't think we really know. At times, because of the male to female difference, it's about 4 to 1 male to female. People looked at the X chromosome thinking it might have had a protective factor there, but I think that's been discredited now. There's thoughts about maybe that autism might present differently in female sex or female gender expression. So now we're identifying more female presenting people with autism. Adults are now being diagnosed with autism more as they are seeking clarification. And then we're understanding also how some people who may be less outwardly profoundly affected by autism might actually still have autism. So people that are struggling with social communication but maybe doing well at work or in school. The other co-occurring increase right now is around intellectual impairment and intellectual disability. People living with profoundly impacting IDD has actually doubled from 2008 to 2020, and there's definitely a relationship or an connection between people affected by autism and co-occurring conditions. So again, the spectrum is huge, and goes from what I'm going to go to next, the word profound autism, to people like Greta Thunberg. Self-advocates and families, I think, have taught me a lot. They have really challenged the way physicians and clinicians talk, the way we throw diagnoses around. And something that they're bringing up right now is, and I'm listening very carefully, is a topic around the word profound. And so in a recent report by the Lancet Commission in 2021, there was a report put out that advocated for the use of the word profound autism. I understand where it comes from. I work within the community of people that is profoundly impacted by neurodevelopmental disorders, and it is there are different needs and different population than people that are able to function and able to succeed in life. Self-advocates, however, have talked about how they don't want autism spectrum disorder to be divided into profound and other. And they feel that it's a very ableist and non-inclusive way of looking at things, and they don't want to disable the autism community. And so I completely agree. And again, I listen to what they're teaching me. My way of thinking about it is not the autism itself, but it's the impact. So I tend to use a language about profoundly impacting autism or profoundly impacting neurodevelopmental disorder. Going back to what I talked about before, again, the spectrum, we have people that are more profoundly impacted. And again, that patient population tends to have associated or co-occurring profound intellectual impairments, so FSIQs under about 50, difficulty with verbal or word-based communication. And then we have people that are less outwardly impacted. Other reasons why the incidence is kind of increased and spectrum is broadening is that we're identifying what's called, I'm not sure if it's an official term, but I call it the female autism phenotype. And again, understanding where autism came from, where the diagnoses came from, where the whole DSM, it was based on one representation of what autism looked like. We're really learning that female presenting people have a different expression. And words that are commonly used would be masking or camouflaging. And so female people, and I use that term to include anybody who identifies as female, just tend to present differently than their male counterparts. And so the female autism phenotype, I think, is something that you really need to be aware of. And even though somebody might be communicating well or making good eye contact or a bit social, you have to really think about whether or not autism is leading to difficulties in school, at home, or with friends. So as mentioned, the female autism phenotype, I think, is something that you really need to pay attention to, because the tools that we traditionally use to diagnose autism are based on a male expression. And I think that there's a huge amount of diagnostic bias in the tools. And so females in general, at least the female autism phenotype, the way I formulate it, there's fewer of the RRBs, but you have to look at how kids are actually using their communication. So people will often confound ability to speak very well, ability to use language and words, with an ability to communicate well. And So in general, this presentation is somebody who can speak well, but that their use of language socially is actually has a lot of challenges. And so this presentation usually has difficulty with peers at school, tend to do quite well because they're busy not having difficulty. And so teachers and schools tend to think that things are good, and then they come home and have a huge meltdowns because they've been like focusing so hard on presenting and masking and camouflaging. There's a new term going around, which I laugh every time I read it, but I think it really describes the situation well. It's called after school restraint collapse. And so again, kids in school are doing great. The teachers have no concerns, but parents come to you and they say everything is completely different at home. You know, child comes home from school and they have just meltdown until bedtime. And so you really need to pay attention to that when parents tell you that. That maybe it's a form of like very, very busy masking. Another topic I think that's come up lately for me quite a bit is pathological demand avoidance. And again, it's a term I don't like it. I don't like the word pathological in description of any child, and PDA is what it is, but the language itself is terrible. So some people call it extreme demand avoidance, EDA. I think it's actually embodied anxiety. I think that we should just call it anxiety. I think it was in the early 2000s, Elizabeth Newsom came up with it, and she actually felt that it was anxiety. So I think we need to go back there. But PDA is I have seen it many, many times. And again, it's not a parenting problem. It is a difficulty or challenge between a system that doesn't accommodate for children with different needs. What it's called right now is an obsessive resistance to everyday demands and requests. And these are kids that won't brush their teeth, that won't take a shower, that you ask them to do anything and they automatically say no. They might be having, incontinence because you've asked them to go to the bathroom and they refuse, right? These kids don't really respond to traditional ABA therapy because there is no the function of behavior is really, it just does not respond to traditional therapy. So parents are telling you, or people are telling you that, they've tried everything. Don't send them to another parenting group. Like this is it's a real challenge on family function. I laugh sometimes, but it's not because it's funny. It's just overwhelming how hard things are for some families and patients. Another interesting thing I've learned in working with the autistic communities is about about gender and gender expression. There is a larger proportion of people than in the neurotypical community that actually identify as non-binary. There's a large cross-sectional study, about 650,000 people that identified people with autism as between 3 to 6 times as likely to have, sorry, it was the other way. They did a 650,000 cross-sectional study, and they identified that those with gender queer expressions had 3 to 6 times as likely to be autistic. And so the thing that I tend to really try to remind myself is that when I'm working with people or youth that identify as autistic, to keep that in mind and keep asking and not just assume that that things stay the same. And so if you talk about gender expression on the first day you meet them, make sure you bring it up again, because I think with trust, people will be telling you more about who they are in total. So then the another point I want to bring up is what I call the triple A's, and I don't think I'm the first one to come up with that. But when you have a person with autism, almost always, which I don't ever use the word always, you'll have ADHD, anxiety, and autism. They travel together. If you have one, look for the other, and if you have two, you most certainly have the third. So don't get caught up in your diagnostic kind of narrow vision, because potentially if you're working with a person with ADHD who also has anxiety, maybe giving them medications for ADHD or anxiety isn't going to address the underlying issue. Maybe what you need to think about is, oh, could things be actually happening? Could this be an expression of autism as well? So 50 to 70% of individuals with autism have ADHD, and about 40% of individuals with autism have anxiety. And as I mentioned before, working on this idea or thinking that behavioral dysregulation in the autistic community is actually an expression of profound anxiety, because I really don't understand what could drive behavioral dysregulation. I think it's just that mismatch that kids their needs aren't being met by our systems. All right, the last thing I want to talk about, that is actually quite a significant issue, and I mentioned it earlier, I think when I was talking about sensitivities, is food. ARFID, so avoidant restrictive food intake disorder, is a huge problem when working with autistic children. It's not picky eating, it is eating 2 or 3 things, and families do everything they can to try to increase the food intake of their child. But if they don't eat anything, or they dysregulate, or, parents, we need to feed our kids, and them not eating is incredibly hard to watch. Pay attention when people or parents come in with children and they say they have picky eating, because it can be 3 things. I call it the white diet: chicken nuggets, fries, and potatoes, maybe. So just pay attention, because this might be your first indication that this could be autism. All right, so that's it for part 1. Thank you very much. I hope you'll join me for part 2 and 3.
I hope you found value in this session, and I'm optimistic that you've learned some new things. We look forward to you joining us for the second installment of the Autism in Primary Care Education series, where we delve into the crucial topics of surveillance and screening, and explore the necessary steps to take when autism is suspected. If you have any questions or would like to know more about the Ridge Meadows Autism Project or the Autism Toolkit that was mentioned in this series, please reach out to Ridge Meadows Division at rmdfp@rmdivision.ca. I will leave you with a thought-provoking quote from Stuart Duncan. Autism is not a disability. It's a different ability. Thank you for watching.